students, in this session we are going to discuss a very important virus, that is human immunodeficiency virus. This causes this famous disease, acquired immunodeficiency syndrome. So this belongs to the family Retroviridae. As we have seen in the general class, it is an RNA virus. So we'll be discussing the morphology, the antigenic structure, pathogenesis, then the clinical features, stages of HIV, the opportunistic infections in HIV, laboratory diagnosis, treatment, and prophylaxis. So these are some of the previously asked questions from this chapter, that is laboratory diagnosis, morphology, pathogenesis, modes of transmission, and opportunistic infection. This can be a possible essay question for your exam. So when you say about HIV, it belongs to the family Retroviridae. You call them commonly as retroviruses. They are RNA viruses. And why you call them as retrovirus? Because they possess a special enzyme called reverse transcriptase enzyme. Normally we know what happens. What is transcription? DNA getting converted to RNA is translation. No? But this virus has RNA genome and it will convert its RNA to a viral DNA, and this is done by the reverse transcriptase enzyme. So reverse transcriptase enzyme causes reverse transcription, conversion of RNA to DNA. So this DNA can go and get integrated into the host cell DNA. So it can get integrated into the host cell DNA. So that is why it can lead to latency, long-term latency of HIV. The reason is integration of the proviral DNA into the host cell chromosome. So the enzyme which is very important for this retrovirus group, it is the reverse transcriptase enzyme. That is why you call them as retroviruses. We have two serotypes for HIV, HIV 1 and 2. Both of them are seen in our country. We have cases. Sometimes we even see co-infection, both 1 and 2 together infecting a person, because the mode of transmission is the same. So when talking about the morphology of HIV virus, they are spherical enveloped virus. Like most of the viruses we have seen, most of them are spherical and enveloped. Size is like 90 to 120 nanometers in diameter, so it's of a moderate size, and it contains two identical copies of single-stranded RNA. So RNA viruses, most of the RNA viruses are single-stranded RNA, but for HIV, it has got two copies of single-stranded RNA. So the reverse transcriptase enzyme is found to be attached to this viral RNA, and this viral RNA core is surrounded by a capsid. You together call this as the nucleocapsid. And surrounding this virus has got an envelope. So you can see the two strands of viral RNA here. Attached to the viral RNA, you have the reverse transcriptase enzyme. Also, there are certain other important enzymes in HIV like protease and integrase. Surrounding the viral RNA, there is the capsid, and this capsid is composed of P24 antigen. So the core antigen is P24 antigen, and here you can see the matrix. This is the matrix region or the matrix antigens. You can also call them as the shell antigens. These shell antigens are composed of P55 mainly, and outside surrounding this matrix or the nucleocapsid, you have the envelope which is composed of the lipid membrane, and from the envelope there are proteins which are spiking outside. You can see the outermost one, which is the outermost spike is called GP120 antigen, and the intermembrane, that is the transmembrane protein, is called as the GP41. So what are the outer spike proteins of HIV? It is GP120 and GP41. Actually, GP120 helps in attaching the HIV virus to the lymphocytes. This virus, it has got affinity for the CD4 T lymphocytes. It is the GP120 that attaches to the CD4 molecule of the T cell. And GP41 is a transmembrane region. This helps in fusion of the virus to the host cells. So don't forget the structure. Morphology is very important. You have to draw this diagram when morphology of HIV is asked. Two RNA molecules, the enzymes attached to it. What is the most important enzyme? It is the reverse transcriptase enzyme. Surrounding this, you have the core region, and the core region is composed of the capsid, that is the core. The core region is composed of P24 and matrix region or shell antigen outside, and surrounding which you have the envelope with GP120 and GP41. So you should just know what are the genes that code for these antigens. HIV has got three major genes. Which are they? They are the GAG, the POL, and the ENV gene. How you can remember it easily is ENV is for envelope. ENV is for envelope. What are the envelope antigens? It is GP120 and GP41. So that is the antigen which is coming out from the HIV envelope. The antigens protruding outside is GP120 and GP41. So this is GP120 and this one is GP41, right? So this is coded by the envelope genes, ENV gene. And pol means, just remember polymerase, pol for polymerase. So the enzymes are coded by the pol gene, especially the reverse transcriptase enzyme, then the protease. And the enzymes are coded by reverse transcriptase is actually an RNA dependent DNA polymerase, right? You're making DNA from RNA. So reverse transcriptase is a kind of polymerase. So POL is for polymerase, that is reverse transcriptase. In addition, HIV has another gene called GAG gene. GAG gene codes for the core antigen and the shell antigen. So what is the main core antigen? It is P24. And what is the main shell antigen? P55 and P18, which make up the matrix region. So these are the important genes of HIV. Now, how will a person get HIV? What are the mode of transmission? It can be through different modes, and the most common modes are sexual contact, sexual transmission, that is the most common mode. Then there is a parenteral route. Parenteral route means it can be blood transfusion or it can be through IV drug abuse. Similar to parenteral, you have one more route, that is percutaneous route. So percutaneous route is most commonly happen in needle stick injury. So we as healthcare workers are very prone to have this kind of injury, needle stick injury. So that's why you have to take all the precautions, universal precautions. We always emphasize on that. Why? Because a percutaneous route, if you get a needle stick injury from the needle which is contaminated with the blood of an HIV patient, you can get the disease. So that is called the percutaneous route. What are the parenteral route? Through the veins, something is going inside the veins. It can be through infected blood transfusion or in IV drug abusers if they are sharing the needles and syringes. In all these cases, transmission of infection is very easy. Then perinatal transmission. What is meant by perinatal transmission? Perinatal transmission is from mother to child. It can occur during delivery through placenta. It can occur through placenta. It can occur during delivery. It can even occur through breast milk. So that is actually debatable, the breast milk transmission, but still placental transmission and during delivery, the transmission that happens perinatally, it's very common from mother to child. So if a mother is infected with HIV, baby has very high chance of getting the disease. So sexual transmission, parental and percutaneous transmission, and perinatal transmission, these are the three common modes of transmission of HIV. Now we are going to see the pathogenesis, how this virus causes the disease. So the pathogenesis actually, it includes how the virus replicates also. So you can see the different steps in the pathogenesis of HIV. So here this is the HIV virus. So what is there in the surface of HIV virus? It has got a GP120 and GP41 antigen. And this HIV virus, it likes the CD4. So this is the CD4 T lymphocyte. So CD4 T lymphocyte is the target cell for HIV. So this one has a CD4 molecule on the surface. Also, it has got certain co-receptors like CCR5. So both these receptors have to interact with the GP120. Then it leads to attachment of the HIV virus into the cell. So here there is the attachment, that is GP120 binding with the CD4 leads to attachment. Once it attaches, the GP41 helps in fusion of the virus with the cell membrane. Thus the virus fuses with the cell membrane, and after that what happened? Now once it fuses, only the nucleocapsid comes inside. So this step is called uncoating, because the coat of envelope is removed. So it is uncoated and coming inside. Once it comes inside, it will lose the nucleocapsid also. So there is proper uncoating and only the nucleic acid is released. So what nucleic acid does it have? It has got an RNA. right? Two copies of single-stranded RNA. Now the next thing this virus is going to do is, there is something closely attached to this RNA. What is that enzyme? The reverse transcriptase enzyme. So reverse transcription is going to happen. This red one is a DNA. RNA is getting converted to DNA by the reverse transcriptase enzyme. Now this DNA, what it is going to do is, it want to go and integrate with the host cell chromosome. You call this DNA as proviral DNA. So this proviral DNA is going inside. You can see this is the host cell DNA, and this viral DNA is getting integrated into the host cell DNA. And how does this happen? This is because HIV has an integrase enzyme. That is what helps in the integration. Now then what happened? This can lead to latency. The latency of HIV disease is because of this proviral integration. It can remain integrated in the host cell chromosome for a long time. At the same time, viral replication will be progressing. More and more CD4 T lymphocytes will be affected. So after this viral DNA, it is again exported into the cytoplasm, where it is transcribed into RNA, and translation of the RNA takes place. All these things happen with the help of the host cell machinery. So translation will lead to production of the viral proteins. Okay, so at the same time, why this want to make a DNA copy initially? Because it want to make it integrated into the host cell chromosome. Later on, this DNA is transcribed into RNA in the cytoplasm of the cell. It is translated into proteins, and these proteins will get assembled, and this protein will be formed as a long polypeptide chain, which is broken down by the protease enzyme of HIV into individual proteins. So these proteins will be assembled together, and when after assembly, it will be budding off from the cell outside. And during budding off, it will acquire a part of the cell membrane along with it. That is how it gets the lipid envelope. It is actually acquired from the host cell membrane. So it comes out, and the whole virus is coming out. It is attacking the other cells now. So HIV virus can come out of the cells by budding, and also it can happen by cell lysis. It can destroy the CD4 T lymphocyte and come out. So that can lead to reduction in the number of CD4 cells. More and more CD4 cells are affected, more number will be destroyed. So these are the steps in the replication and pathogenesis of HIV. The first thing is attachment. GP120 to CD4. Next thing is fusion by GP41. Next comes the uncoating, where the nucleic acid comes out. Next is the reverse transcription, where it makes us the proviral DNA. Next is integration, where it integrates to the host cell chromosome. And then later on, it can lead to transcription and translation, forming the viral proteins. Finally, the viral proteins get assembled and they are released from the cell. So these are the steps in pathogenesis. This can be asked. If pathogenesis is asked, you may have to write all these things. So entry into the bloodstream, HIV comes into contact with CD4 T cells. We have seen all these things. RNA is transcribed by reverse transcriptase into DNA. So the provirus or proviral DNA that will get integrated into the infected cell's genome, that leads to latent infection. So CD4 T lymphocyte count decreases as the infection progresses, and you can see a reversal of the CD4-CD8 ratio. Normally, CD4 is more than CD8, but when HIV infection occurs, the ratio will be reversed. We'll see what are the stages of HIV infection. You have actually 5 stages. You can classify it into 5 stages. Initially, the patient gets exposed to HIV infection. They are acquiring the infection, and initially during that period, they may be having some acute prodromal symptoms just like any other viral fever. After that, they go in for an asymptomatic stage. This is because of the latency and proviral DNA. And during this time, even if it is latent, the virus will be multiplying in the lymph nodes, so the patient will be having persistent generalized lymphadenopathy. Now what happens is, after some time, when the body's CD4 count drops to a certain level and the body's immune system is not able to cope up with it, what happens is the patient will start showing symptoms. You call that as AIDS related complex. And the common symptoms they show are persistent fever, persistent weight loss, and persistent diarrhea or intractable diarrhea. So fever, weight loss, and diarrhea without any other cause, that is what is happening initially in HIV, how they present. So if you see this triad in a patient, you have to rule out HIV. And also they will show some mild opportunistic infections like oral candidiasis, recurrent bacterial infections and all in this stage. Later they go for a full-blown AIDS stage where they will be having all these symptoms. Along with that, they will show neurological disease that is called HIV related encephalopathy. The HIV virus as such can cause an encephalopathy. They can cause severe opportunistic infections like various infections. It can be Cryptococcus, Pneumocystis, CMV, Mycobacterium, atypical mycobacterial illness and all. And certain cancers which can be associated with HIV, that is Kaposi sarcoma. All these are seen in this last stage when the patient develops a full-blown AIDS. So acute HIV infection will be having fever, malaise, sore throat, arthralgia, myalgia, anything can be just like any other viral fever. In latent stage, you will get a positive HIV antibody test, but no clinical features will be present. Only they will be having persistent generalized lymphadenopathy. Now, in symptomatic HIV usually occurs when CD4 falls below 400 per millimeter cube. They will have fever, diarrhea, weight loss, and opportunistic infection. Finally, they go in for a full-blown AIDS. So you should know what are the oral manifestations of HIV. So HIV has got a greater risk for bacterial, viral, and fungal infections of mouth. Any kind of infections can be more recurrent and more severe in an HIV patient because it's the CD4 count that is dropping. Just imagine it's the helper T cell. If CD4 count drops, they are more prone to get infections because their immunity is very bad. So dental caries and gingivitis can occur recurrently. Acute necrotizing ulcerative gingivitis can be more severe, like necrotizing and ulcerative. Herpes infections, HSV infections are more common, may be present as multiple, deeper and more painful oral lesions. Hairy leukoplakia is another thing. It is hairy. Hairy leukoplakia, it's an early sign of immunodeficiency, and oral candidiasis is present in most of the patients. That is called as oral thrush. So candidiasis in HIV, it can be erythematous candidiasis lesions on the palate and tongue, or it can be like this, angular cheilitis, fissures and ulceration, erythema in the corners of the mouth, angular cheilitis, or it can be mucocutaneous candidiasis. So these are some of the oral manifestations of HIV. Now, another question that can be asked is what are the opportunistic infections that one can have in HIV, that you can see in an HIV patient. So there are bacterial, viral, fungal and parasitic infections. You have to memorize a few of the infections from each section. Bacterial, the most common bacterial infection, opportunistic infection in HIV is the mycobacterial infection, both tuberculosis and non-tuberculous. Among non-tuberculous, this is more common, Mycobacterium avium complex infection. It resembles tuberculosis. Then salmonellosis, especially non-typhoidal salmonella, is more common, be causing opportunistic infection in HIV patients. Non-typhoidal salmonella. Coming to the viral opportunistic infections, this is cytomegalovirus. It can cause retinitis in HIV patients when the CD4 count falls below 50. Similarly, HSV can cause various infections, skin lesions and encephalitis, genital lesions. Varicella zoster, mainly causing herpes zoster, can be seen in HIV. Epstein-Barr virus infections can be there, more disseminated Epstein-Barr virus infection. Then HHV6 and HHV8. Actually, HHV8 causes Kaposi sarcoma. That is a cancer associated with HIV. So these are some of the viruses causing opportunistic. Better remember CMV, herpes simplex, varicella zoster, and human herpes virus 8. Coming to the fungal infections, fungi which causes opportunistic infections, Pneumocystis jirovecii pneumonia, it's an opportunistic fungal infection. Candidiasis, it can be oral candidiasis, it can be esophageal candidiasis. So both can happen. And cryptococcosis, what does cryptococcus cause? We have already seen in the fungal class, that is meningitis, then aspergillosis and disseminated systemic mycosis, histoplasmosis, coccidioidomycosis. All these can happen in HIV. Parasitic opportunistic infections, toxoplasma. Toxoplasma causes encephalitis. Cryptosporidiosis causes severe diarrhea. Not only cryptosporidium, cyclospora and isospora. So I have told the examples of parasites causing diarrhea in HIV patients: Cryptosporidium, Isospora, and Cyclospora, and generalized strongyloidiasis. So these are the parasitic infections causing opportunistic infections in HIV: Toxoplasma, Cryptosporidium, Isospora, Cyclospora, and strongyloids. So what are the malignancies associated with HIV? Kaposi sarcoma. It is actually caused by HHV8. And B cell lymphoma, non-Hodgkin's lymphoma. All these can happen in HIV. So now we are going to see how we'll diagnose HIV infection. You have specific and non-specific tests. So first we will see what are the specific tests for HIV. So you can detect the presence of antigen, or you can detect the presence of antibody, or you can go for a viral RNA detection by PCR. So we have three kind of tests: antigen detection, antibody detection, and PCR for viral RNA. So these are the specific tests. Antigen detection is a very good test for HIV, and the best antigen that comes first is the P24 antigen, which is the core antigen. So that is the first viral marker that is present in patient's blood. Antibodies will take some time to appear, like 3 weeks, or it will take more than that. So even within a shorter period, like within 10 to 12 days, you can get a P24 antigen positive. So this can be detected by ELISA test. Now, coming to the next test, which is specific for HIV, that is what I told you. You can detect the viral nucleic acid by PCR. What PCR? You have to go for an RT-PCR. And virus isolation, it is reserved for only rare instances where you have some special indications to culture the virus and find out the things, if the other tests are negative or not, or for research purpose. Generally, we don't do viral culture for HIV routinely. The more important ones are antigen detection, which antigen? P24 antigen, and also viral RNA detection by PCR. And we have the other test, that is the antibody detection. So this can be detected in 3 to 4 weeks post-infection. Antibody will appear only 3 to 4 weeks after infection. Initially, it will be the IgM antibodies, which will be later followed by the IgG antibodies. So what all tests can you use for detecting antibodies? We have two types of tests for detecting antibodies. One is called screening test and the other is called the supplementary test. So screening test, we have your ELISA test and the rapid CART test are available for screening. So what you're going to screen? You're going to screen for the antibody, presence of anti-HIV antibody in patient's serum. And ELISA, we have recently different generations of ELISA are available. Now we have the 4th generation ELISA, which can detect the anti-HIV antibody along with P24 antigen. So we have 4th generation ELISA for HIV available, which does not only detect the antibody, but it can also detect P24 antigen. So this helps in reducing the window period. That is, antibody will take some time to develop. So if you are going to test a patient a little more earlier, if P24 antigen can be detected, is very well and good, because you can pick the case earlier in that case. So that is the advantage of the 4th generation ELISA test. Then you have the rapid test for screening, which is based on immunochromatography. You call it as lateral flow assay, where you have a card, you have a control line, and you have a test line. If you get the control line and test line positive, you consider it as positive. So that is a rapid card test, immunochromatography. Similarly, you have other tests like tri-dot test. So this will be a control band. This will be HIV1, HIV2. You are quoting the antigens for HIV1 and HIV2 here. You add the patient's serum. If the patient's serum contain anti-HIV1 antibody, you get this dot positive plus the control dot positive. If it is HIV2, you get this dot positive. If 2 of the serotypes are present, you get all the 3 dots positive. That is HIV tri-dot assay, and the principle of this is immunoconcentration. So what is the supplementary test we have for confirming? If you get a screening test positive for HIV, you have to do a supplementary test. You have to do a supplementary test to get more confirmation. That is the Western blot assay. Advantage of Western blot is you can detect antibodies to all the antigens separately, like GP120, GP41, P24, P15. Everything can be detected separately if you are doing a Western blot test. So it is based on blotting, immunoblotting mechanism. So those were the specific tests for HIV. Lab diagnosis of HIV is very important. You should also know what are the non-specific tests. You can look for a total and differential leukocyte count. Normally patients will be having leukopenia and the T lymphocyte subset assays can be done. See, CD4 count will fall below 200 in case of HIV if they are developing the symptoms, and the ratio will be reversed. Like normally it should be 2:1, but in case of HIV you have a reversal of the ratio 0.5:1. Coming to the treatment, what is the treatment of HIV called as? It's called highly active antiretroviral therapy, HART, or you simply call it as antiretroviral therapy. We have a number of drugs available for treating HIV and we generally treat in a combination manner. You have the reverse transcriptase inhibitors, which is nucleoside analog or nucleotide analog or a non-nucleoside. So whatever be the compound, it should inhibit the reverse transcriptase. It should inhibit the reverse transcriptase enzyme. Then comes the protease inhibitors, which inhibit the protease enzyme, fusion inhibitors, which inhibit the fusion of the cell, integrase inhibitor that inhibits the integrase enzyme, entry inhibitors, which will be acting on the CCR5 receptors. And generally, what you use for treatment, we use a combination, and this is the normal regime that is being accepted now. We give a combination of 3 drugs. Lamivudine plus efavirenz plus tenofovir is what we use for the treatment of HIV in most of the patients. So you can see the examples of different groups of drugs. This is nucleoside reverse transcriptase inhibitor. Example, you can remember one, that is lamivudine. Okay, and then there is nucleotide reverse transcriptase inhibitor, tenofovir. Non-nucleoside reverse transcriptase inhibitor, you can remember one, that is efavirenz. So this is what I told you. What we commonly use for treatment is tenofovir plus lamivudine plus efavirenz. So tenofovir is nucleotide analog, lamivudine is nucleoside analog, and efavirenz is non-nucleoside analog. Example for a protease inhibitor, you can remember intinavir, fusion inhibitor enfuvirtide, integrase inhibitor raltegravir, and entry inhibitor maraviroc. So these are the advanced drugs. At least remember TLE, tenofovir, lamivudine, and efavirenz. So you also have to treat the opportunistic infections in HIV, not just HIV. You have to treat the opportunistic infection. If it is TB, if it is pneumocystis, or if it is whatever it is, candidiasis, you have to treat the opportunistic infection also. So we have to give the specific drugs for different opportunistic infection. Now you should know what is the post-exposure prophylaxis. As we are all healthcare workers, we may be exposed to needle stick injury or body splashes of blood and body fluids. So if it is from a positive patient, you have to take the post-exposure prophylaxis. So that will depend upon the category of exposure and status of the source patient. So what you have to do is you have to start the treatment within 2 hours, or at least within the first 72 hours. So that should be started immediately and it should be continued for a period of 4 weeks. 1 month you have to take the treatment. And generally we take the same regime for prophylaxis also. Tenofovir plus efavirenz plus lamivudine is taken for treatment also. So tenofovir plus efavirenz plus lamivudine is the treatment for prophylaxis. For the prophylaxis also the regime is the same. So that is about the different aspects of HIV virus. It's a very, very important topic. I'm repeating. Please be thorough with all the important questions that were previously asked. It's almost a 90% sure question for exam. HIV is always asked in exam. So please be thorough. Thank you.